Hello, everybody. I'm Dr. Mohamed from the Sandton Fertility Centre, and today we're going to talk about low-dose IVF. I want to just state that this concept of low-dose IVF has changed over the years, and it is now interchangeably used with low-cost IVF. The two have become synonymous. This concept was started approximately 10, 15 years ago by a lady in England called Dr. Gita Nargand. And over time, this concept has grown and become popular. Recently, Dr. Gita Nargand has actually sold her organization to an American organization for $600 million. So you can see that this concept of making IVF cheaper, there's a lot of money behind it. So we'll just talk a little bit about how IVF is done, and then talk about the costing and who actually should have it. So if you look at the chart in front of you there, it starts off by diagnosing the patient, what is the problem with the patient, examining the couple, and coming to some sort of a diagnosis as to what the problem is. And then if they're going for IVF, the first step is to do some bloods, and depending on those bloods, we normally choose the dose, and we have a series of injections that are given to the female partner, and that goes on for about 12 days. After 12 days, a trigger shot is given, and the eggs are retrieved under anesthesia. And then the embryos are cultured in the lab after fertilization. And of course, we get the sperm from the husband. We then inseminate those embryos into the female partner, and hopefully we actually get a pregnancy, because that is the aim of it. So low-cost IVF and low-dose IVF is also known as mini IVF or minimal stimulation IVF. They all mean the same thing, and we've also given another name that sounds better. It's called patient-friendly IVF, and I will actually explain what patient-friendly and why we call it friendly IVF. So the conventional IVF, the aim of the conventional IVF, where we use normal doses, is to collect about 15 to 20 eggs, and research has backed this up to say that if you get a minimum of 15 eggs or 20 eggs, the chances of getting a positive pregnancy are much better. This has undergone some change, and I'll just mention something about it. But the reason we get about a 40% success rate is because we now calculate the success rate of pregnancy. We call it a cumulative success rate. That means it is a success rate taken together over about 3 attempts. And that is why we actually get such a rate. Actually, the actual success rate of IVF is about 35% for anyone that's below the age of 35. Now, in low-cost IVF or in low-dose IVF, the stimulation is much higher, because we're looking at egg collection of about six eggs. With about 6 eggs, and if we have good sperm, then we will end up with about 2 blastocysts, which we will transfer and hopefully get a 35% success rate. So the fewer eggs doesn't mean it's a bad quality eggs. It's a good quality egg with a low stimulation, and hopefully they are chromosomally normal. So the medications we use are low dose, and they produce about 5 to 6 eggs. Recently, what has happened over time is that although we use lower doses of medication of hormones that are injectable, we found that the same doses or the same drugs that we used to use have additional effects which we hadn't actually realized before, and these additional effects actually lower the cost of IVF further. And I'll give an example of this. There's a tablet called Clomid. It's a pretty low tech drug which induces ovulation. And in the days gone by, we used Clomid as a first line just to induce ovulation. And if anybody walked into a doctor's office, whether it was a specialist or a GP, they would start off and give them for Clomid to start with. They would give it to them about 5 days, and hopefully, she will make 1 or 2 eggs, and they would do an insemination or natural intercourse. But then over time, we found that the Clomid, and although it was known, it wasn't used that way. We found that Clomid is an anti-estrogen. And if it's an anti-estrogen, it actually suppresses the production of LH. LH is the drug that triggers ovulation. So we found that if we use Clomid on a long protocol for about 10, 12 days, we'll be successfully be able to avoid the use of the trigger injection by not using an antagonist in the cycle. And usually we give antagonists in the cycle, which actually costs about 6,000 to 7,000 rand. So we are further able to reduce the cost of a cycle by using Clomid. We have to, of course, this is not a one-size-fits-all type of thing. We have to individualize the patient's protocol, and for that we need to see the patient, we need to see the partners, both partners, and we need to then devise a protocol that will suit that particular couple. So the advantages of a low dose is that of a low dose cycle is that the cost is dramatically reduced. We got about 5 eggs which we actually harvest. Usually it is dramatically reduced. We also can reduce the cost in the laboratory, because instead of doing ICSI, we would do IVF, which would reduce it by another 3,000 rand. We could reduce the cost by using, because we got very few eggs to harvest, we can reduce the cost by not using the services of an anesthetist and doing it under sedation, and also collect only about 5 eggs so that the cost remains stable. This particular low dose cycle is also reduced. There's reduced discomfort, there's reduced pain of all the injections. We have a lower risk of ovarian hyperstimulation syndrome. There are reduced visits to the doctor's offices, reduced number of ultrasounds, which again further reduce the cost. But now, is this suitable for all patients? No. Initially, it was used for patients who were below the age of 35, who were regarded as high responders, who had a lot of eggs, and for example, in the case of polycystic ovaries. But now it is also being used in older patients, because research in the last 3-4 years have indicated that follicles develop in waves. So initially we believed that the follicles only develop or recruited in the beginning of the cycle, and that's the only follicles that we were going to get. But now we know now that we can recruit eggs at any time of the cycle. So they've come out with a system called dual stimulation, where we harvest the eggs from the first half of the cycle. We then take a break of about 3-4 days, and we start again. And we harvest again in the same way. So it has made it much more comfortable and much less expensive to do it that way. Ironically, older patients were not candidates for low-dose cycles. But now they have actually become candidates, because we've realized that you can start the cycle in any time of the month. So if we start the cycle on, say, day 3 with a whole lot of injections, and we harvest 3 or 4 eggs, take a break for about 2-3 days and start again in the same cycle. And you'll get another 2-3 eggs, and we'll end up with a total of about 6, which we will fertilize and then grow into blastocysts. The other advantage of a low-dose cycle is that the incidence of prematurity or multiple pregnancies reduced. And we know that multiple pregnancies carry the risk of high blood pressure to the mother, diabetes to the mother, cerebral palsy to the fetus. So these are not risks that one likes to take lightly. Are the other pregnancy rates the same as conventional IVF? No, they're not the same. They definitely are reduced. The pregnancy rates in a low-dose cycle are definitely reduced. And that is why it is not so popular in high-volume clinics, because the rate of cancellation in these cycles is very high. The success rate is a bit lower, so the patient needs to be counseled extremely extensively, and that takes a lot of time. So that's a bit of a disadvantage. As to the pregnancy rates, cumulative pregnancy rates are higher. So who should have low-cost IVF? Patients who are less than 35 years old are suitable. Patients who have poor ovarian reserve, because then they can be candidates for dual stimulation. At-risk patients for ovarian hyperstimulation. And these are patients known as polycystic ovarian syndrome patients. They are at risk for hyperstimulation. I remember I had a patient who had polycystic ovaries, and we harvested about 25 eggs. I put 2 back, and she actually came in 3 days later with a swollen tummy. Her legs were waterlogged, and she was extremely uncomfortable and with shallow breathing. We had to admit her into ICU for about 3-4 days. It's a life-threatening disease. So if something actually removes the risk of that, it's very commendable. The other thing is that there are some patients that ethically will not accept embryo freezing. And those are candidates for low-dose IVF, because you won't have anything to freeze if you collect a maximum of 5 eggs. So, in conclusion, what I'd like to just show you is a little picture of a 12-day stimulation, which now appears on the screen there. And it's just that it starts off with stimulation, and it starts off the next day, and the 3rd day, there's visits to the doctor for ultrasound and monitoring of the follicles. After about 10 days, it's given a trigger shot. We then harvest the eggs 36 hours later, and then fertilize them with the sperm that's available, after which we insert 2 into the woman, and we freeze whatever's available. Thank you very much.
We have got some questions for you, so let's get started. I know you talked about this, but someone's asked about can everybody do a low-dose IVF?
I don't think everybody can do a low-dose IVF. I think the person that qualifies for a low-dose IVF should be first seen by a specialist and, assessed. The hormone should be assessed, and she should be assessed totally. The best people to do this are people with tubal pathology. That means those tubes are blocked but are hormonally intact. And the lady that I had a lady that walked into my rooms one day, and she was a domestic. I knew she couldn't afford it. She couldn't afford it. So I just gave her, some oral medication. And she was 38 years old, and as luck would have it, she'd produced 6 eggs, which we removed under sedation. And she fell pregnant. But now that luck also plays a big part there. It plays a big part, So not everybody, but people with tubal pathology and people with polycystic ovaries are possibly candidates for this. But they should be assessed by a specialist who would probably choose the protocol after examining her.
And you talked about that it's suitable for older patients. So what would the criteria be for older patients? Would they need to have a relatively high AMH?
No, this is better. This is a newer concept, meaning about maybe 2-3 years. Medicine, there's a pendulum.
Yes.
It's popular 1 year, and then 3 years later it's not,
yes.
And then it comes back. With the older patients with a very, very low AMH, less than 1, we normally tell them, listen, go for a donor, your chances will be better. But there are people, and lots of them, who will not go for it. So those are candidates for this particular low-dose protocol, where you can give them a combination of oral agents with a little bit of FSH, and you collect maybe 2-3 eggs at a time.
Yeah.
And in one cycle, you repeat that twice, and you'll end up with about 4, 5, 6 eggs, ending up with about 2 blastocysts. So this is a newer concept where you target the follicles that you see.
Okay.
Because the follicle that you see is recruitable.
And do you think it would produce better quality eggs for older patients?
You mean, not necessarily, but yeah, sometimes you do. I mean, if you hit a person who's older,
yes.
with a lower MH, you're not even going to get follicles or growth of eggs. Okay. You probably won't get it at all.
And this is not directly related to your chat, but how long should one wait to repeat an IVF procedure? I did one in 2018 and would like to repeat. The reason for my failure was poor egg quality. So how can I also then improve my egg quality?
Well, there's a drug called DHEA, and, we're all using it. We don't know whether it helps or not, but we do use it because it increases the androgen and androgen. So, yeah, you can, if she's had one in 2018, she should do it without waiting too much longer.
Yes, I mean, they only really need to wait a few, how long do you recommend between cycles in general?
I would recommend about a month or 2.
Okay. Yeah. And then during IVF with a PCOS patient taking metformin and folic acid, what other supplements can one take to increase chances of a positive pregnancy test?
Well, like I told you, the Polycystic, they produce a lot of eggs. So the metformin that she's taking is very good because that provides the energy into the follicle for growth. And of course, the folic, they take folic. Aside from that, maybe she could take some ubiquinol, But I hope her vitamin D is okay, because if her vitamin D is not, she should take vitamin D, because vitamin D is actually a hormone.
Okay.
And it will improve egg quality.
Okay. And somebody from Kenya has asked how they can access you while in Kenya. Has international treatment started, or international cycles? Have you had international patients?
Yeah,
okay.
I think all clinics get international patients.
Yeah. And now it's open and...
Yeah. And also some of our clinics we're on Zoom,
Yes, so the consults can be done via Zoom. Initial consults can be done via Zoom.
Consults and investigations can be done on Zoom.
Excellent.
And then they just come down,
Brilliant. So there you go.
Yeah.
Thank you, Dr. Mohamed. That's all for now. If anybody else has got any questions for Dr. Mohamed that we haven't managed to get to, please don't forget to send us an email and we'll liaise with him and send you the answer within a few days.